This video demonstrates a simple technique for endoscopic hypothalamic hamartoma disconnection in refractory epilepsy. Patients with hypothalamic hamartoma usually have refractory epilepsy. Microsurgery using a transcolossal interfornical approach provides good outcomes. However, it requires craniotomy, callosotomy, and may damage both fornices, causing short and long-term memory impairment. On the other hand, endoscopic surgery is well tolerated by patients, avoids the fornix, and carries a lower mortality and morbidity risk than traditional microneurosurgical routes. We present the case of a 12-year-old girl who had had seizures since she was 4. They were caused by hypothalamic hamartoma. This is the presurgical EEG. It shows spike and wave discharges followed by rhythmic theta and delta activities in the left frontal region. Here is the pre-op MRI with the image on the left showing the hamartoma inside the third ventricle attached to the left hypothalamus. The rest of the brain was normal. We planned to access the ventricle using the endoscope and the frameless varioguide system. Once we located the foramen of Monro, we would pass into the third ventricle and disconnect the hamartoma from the hypothalamus. This picture shows the varioguide and the projected route to the hamartoma disconnection site. In the video, we see what we found inside the right lateral ventricle. As we expected, the choroid plexus was covering the foramen of Monro, something that's common in small ventricles. In this case, it was necessary to reduce the size of the choroid plexus with bipolar coagulation to reveal the opening of the foramen of Monro in the center of the image. Several applications were necessary to reveal the foramen of Monro. As you can see, the bleeding is limited. Now, looking down to the third ventricle, we can see the hamartoma and the hypothalamus on the left. Recapitulating, this is the hypothalamus on the left. To its right is the hamartoma, and this is the interface between them. Over here, on the upper right part of the image, is the intact fornix. We pass the bipolar electrode down the ventricle and use it to poke holes in the interface between the hamartoma and the hypothalamus. Normally, the hamartoma won't bleed. Here we can see the holes. And, as you can see, this technique is simple and fast. Next, we use the Fogarty balloon catheter to expand and connect the holes, breaking the tissue down between the holes that separate the hamartoma from the hypothalamus. This technique did not disturb the base of the hamartoma and respected the perforate vessels. This is the last disconnection of the posterior part of the hamartoma. Here in the post-surgical EEG, we can see a practically normal background activity despite some irregularity and spiky physiological sleep transients. The post-op MRI showed the hamartoma is completely disconnected from the hypothalamus. The patient has had no memory problems, no hormonal alterations, and no seizures since her surgery. She's one of 5 patients we have operated in the last 3 years, and they have all had the same excellent results. In conclusion, we think this technique is simple and fast. It took 40 minutes from the time we accessed the foramen to the end of the procedure. We believe it's a good option for hypothalamic hamartoma surgery.